Then, good morning. My name is Caitlin, and I'd like to introduce and welcome two of our wonderful guests who are going to talk with us today about aligning organ donation and palliative care to support patients and families. They have a presentation for us, and then we should have some time for some questions and answers. So we have two guests. We have Kristen Matheson, who serves as a family support specialist with Versity, a chaplain for Ascension Milwaukee's Metro Hospitals, and a fellow co-host of Friday Chalk Talks. And when she's not at work, she enjoys hiking, birding with her husband, reading mystery novels, and playing the piano. So amazing jack of all trades. And then we also have Michelle Finke, who began her nursing career with Children's of Wisconsin as an ICU nurse before transitioning to Versity, where she's been for the past 6 years. And she finds immense joy in her work and helping families navigate the donation process. And of course, also in educating and finding new ways to collaborate with hospital staff to ensure the best possible outcomes for the donor, their family, and the recipients. And a fun fact about Michelle, which I truly love, is that she runs a sourdough micro bakery out of her home. And sadly, we have no samples today for you all to enjoy, but I think that's wonderful. So take it away, you two.
I'd like to just start off with who are we? So we work for Versity Organ and Tissue, and we are one of 56 federally designated organ procurement organizations in the United States. And we service Southeast Wisconsin. So you can see there on the picture the counties that we serve. We have a rather small area, which I particularly love. That means that I get to be home with my family every night. Some others in our OPO friends cover much larger areas, and so they aren't able to be home with their families every night. So I'm fortunate that we work where we do. We are kind of governed by CMS, just like hospitals are. We're considered a healthcare institution, and we are mandated by federal law to facilitate organ donation in our service area. We cover about 55 hospitals and serve about 2.3 million people in our service area. We also provide public and private education to everyone in the state of Wisconsin, along with our friends at the UW-OPO. So just to start off with some basics about organ donation. So there are two pathways to donation. There's the brain death pathway, and then there's the donation after circulatory death pathway. So in donation after brain death, the patients unfortunately suffered a significant neurologic injury. They, because of that injury, have lost all of their brainstem reflexes. Brain death testing ensues. And if all of those tests are consistent with brain death, the patient is declared deceased at that time. Brain death is a legal and a medical diagnosis. And the donor at that point would go to the operating room with the breathing tube in place. In a donation after circulatory death scenario, patient again suffers a severe neurologic injury, but not so severe that they lose all of their brainstem reflexes. So they may still breathe, have a respiratory drive, they may still have pupil reflexes, but they're not going to be the person that they were before the injury. And that family lovingly chooses a comfort-based plan of care for their loved one. In some instances, those patients are still eligible to be organ donors, but the process is a little bit different. In these particular instances, the patient is actually extubated to comfort measures, and if their heart stops within a certain time frame, generally that's 60 to 120 minutes, the surgery can then take place. These patients are generally, depending on the hospital, they're generally extubated in the operating room simply so that we're in the right place for the surgery to take place if they do pass in that time frame. And families are allowed to be with their loved ones in the room until their heart stops, and then we escort them out. So they're still able to be with their family member during the dying process. So we've got only a short time, and I could talk about organ donation for hours, but I wanted to give you a short kind of start to finish on the organ donation process. So How do we even get involved, right? So the RN at the bedside notifies the organ procurement organization when a patient meets certain clinical triggers. Here at Versity, our clinical triggers include, but are not limited to, a GCS of 5 or less, any end of life conversations, of course, if a family were to bring up organ donation, anything of that sort, they'll call us and make the referral to us. We immediately, as the organ donation specialist, I'm one of the ones that gets those pages. And I start looking at that patient right away. Look at their past medical history, what's their current status, what brought them in, what's going on, where are we at right now, and try to figure out and discern if that patient is actually an organ donation candidate. Oftentimes, what happens is we'll end up following that patient kind of in the background for several days and even weeks at times until either they get extubated, hopefully, right, and get better, or the patient progresses to brain death, or the family chooses a comfort-based plan of care. So once those goals of care meetings begin, that's oftentimes when palliative hospice is getting involved with the family. And also, we're getting notified at that same time that the family is discussing end of life. So I've got those stars there just to denote some times where a collaborative conversation between the palliative hospice team and our team would be a good opportunity. If we know that the family's having end of life conversations, we're going to head on site. Not necessarily because we know that the family's made a decision or the decision is happening today, but we do want to be able to be present so that if they do make a decision, we're able to be there and talk to them right away. We don't want anyone to have to wait around for us. Ideally, the family would consent to donation after we talk to them, or support their loved one's choice to be a donor. And this is a really good, important point. Organ donation from the time of consent to the time of the surgery can take anywhere from 1 to 3 days. We understand and acknowledge that the families have to give us time in order to help support their loved one's decision to be a donor. And we are grateful for that. And we honor that by working as quickly as we can, but also we want to maximize that donor's gifts and allow them to help and save as many lives as possible. Once the organ workup happens and is completed, then we'll go to the operating room for recovery. So where do our roles intersect? Anytime the family is having end-of-life conversations, this includes hypotheticals, right? If you're going in, you've been consulted, and you're going in, and the family just wants to know, like, what are our options here? That's a time where our roles could intersect. And end-of-life planning may look different depending on whether the patient has chosen to be an organ donor. And for that, I'm going to pass that along to my colleague, Kristen, and she's going to explain a little bit more about the family support and where we go from that.
Thanks, Michelle. As previously mentioned, I work as a family support specialist at Versity. And in that role, I have the privilege of approaching families about the opportunity for organ donation and supporting them through the donation process. Michelle has talked about the work we do in the background to assess if a patient is a medical candidate for donation. We also work behind the scenes to try to assess if families might be ready for the donation conversation. And we do that through a review of a patient's EMR and through on-site conversations with care teams such as yours. Over the decades, organ donation professionals have come to understand that the ideal time for the donation conversation happens once we can confirm 2 things. 1, the family understands the poor prognosis, and 2, the family has a relative degree of emotional acceptance about the non-survivability of the injury. This acceptance could be demonstrated through discussion of funeral homes, things, withdrawing care, things like that. When we wait to approach families until these 2 criteria are met, we are able to reduce misunderstanding and to protect the rapport and trust the hospital care teams have already built with the families. Imagine if a family doesn't even understand that their loved one's injury is not survivable and the organ donation team comes in. Well, they're going to think that the hospital only cares about organ donation, isn't trying to save their loved one. So the timing of this is very important. Now, if families come to an understanding and acceptance before they make a firm decision to transition to comfort measures, and we see this a lot when families are waiting for out-of-town relatives to come in, maybe they know someone's flying in on Sunday, then we are able to speak to them before they reach a level of emotional exhaustion that might lead them to object to donation for timing reasons alone. And the reason that's important is it's because of those families who often come back to us and express regret over having declined a donation. So we want to protect these families from multiple not ideal scenarios. We've spoken thus far about families, implying an answer to the question, who authorizes organ donation? The answer is specifically laid out in the Uniform Anatomical Gift Act, also known as UAGA. And the answer is, I believe, important for palliative care professionals to know, because it might differ from the person or people you've been talking to thus far in the patient's hospitalization. As we all know, here in Wisconsin, maybe not for long, but in the absence of a healthcare power of attorney, surrogate decision-making falls to family consensus. The UAGA and its adoption as Wisconsin state law has detailed that the decision for organ donation falls either to the individual patient or the legal next of kin. We'll start with the latter. The legal next of kin would first be the healthcare power of attorney, and in the absence of a POA, then the order as you see here on the screen. The spouse, for example, can be a tricky one if the patient is separated but not legally divorced from their spouse. It would still be the spouse who would get to make the decision about organ donation. I was surprised by this when I transitioned from chaplaincy in the medical ICU to the world of organ donation. And I've seen times where these differing laws can complicate the delicate networks of communication and decision-making that exist in ICUs. The healthcare team, for example, may elect a spokesperson that is not the legal next of kin. Or they may be working within a family culture that has distinct hierarchies that do not map on neatly to the order you see here. Our goal is to work within those pre-existing decision-making structures that you all have been so tenderly paying attention to. And we also have to comply with the law. So your assessment of those family dynamics matters a lot in our work. And we often consult with palliative care, chaplaincy, and social work, in addition to the nurses and providers, to create a plan together for how we can have this conversation in a way that respects all of those things I just mentioned. There is one person whose decision about organ donation trumps the power of attorney or legal next of kin, and that is the patient themselves. First person authorization is the term used when an individual authorizes their own anatomical gift before them. Often this happens by registering at the DMV or through websites like registerme.org. Other times an individual communicates this choice in their advance directive, though that section is often skipped, I've noticed. So here's a little advocacy for talking about the organ donation section in advance directive. Supported by the ethical principle of autonomy and the legal principle of gift law, not informed consent, which is again different from all these other decisions that have been happening in the hospital setting. An individual's authorization is binding and cannot be overridden by anyone else, even a family member who might not agree with their choice. When I'm talking to people about this, I like to say the decision for organ donation carries a similar legal weight to the decision of who your power of attorney will be. Cousin Johnny can't come in and say, no, I'm the power of attorney when Sister Elizabeth has been designated. Well, similarly, Sister Elizabeth can't say, no, the patient's not going to be an organ donor if the patient has elected to be one. So OPOs and hospitals work together, supported by UAGA, to honor an individual's decision to be an organ donor. We do this while also centering and prioritizing families' needs, seeking to hear and address them so that families are able to effectively cope with their loved one's voice. Given that difference between UAGA and family consensus, one of the things we ask of palliative care professionals is that when you are educating families about end-of-life decision-making, you preface the decisions they'll have to make by saying something like, for this decision or for this particular decision, your family will need to arrive at a consensus. It is a very small way of signaling to the family that family consensus is particular to certain decisions and not to all that will take place in the hospital. And it gives just a little bit of room for our teams to then work together to create the language necessary to educate and support families around organ donation. Whether authorized by legal next of kin or by the patient themselves, we provide a robust system of support to our donor families. We share therapy resources and connections to grief support groups, along with assistance for grieving children. We provide memory-making items, including heartbeats, handprints, and shawls made by donor families. We support families with funeral home and cremation questions and provide emotional support throughout the donation process. And our aftercare team continues that support in the months and years ahead. They provide families with a connection to a larger donor family community, which can be incredibly meaningful to them. And the governor actually invites donor families to a gift of life ceremony at his mansion in the fall, and families are given a Medal of Honor in recognition of their loved one's donation. We at Versity have an annual family donor celebration, and then of course, a very meaningful thing for donor families is letter writing between them and the recipients. And if both parties choose to do so, they do get to meet. All of this to say, donation is not just life-saving for recipients. That's not the only reason we're going in to talk to families about donation. We do it because it can be a powerful source of healing for bereaved families, which is why we want to effectively partner with hospital care teams and especially with palliative care to ensure these donation conversations are timed appropriately and effectively. And with that, I'm going to hand it back to Michelle.
Thank you, Kristen. So what are some things we want to avoid? We want to avoid a family making hard set plans about what end of life is going to look like, and then the organ donation team coming in and saying, well, your loved one actually chose to be an organ donor, so they're going to stay here for 2 more days. We want to be able to have that conversation while they're making those end of life plans or considerations. We want them to be able to consider that time frame in their end of life planning. We don't want them to feel disempowered by coming in and changing things up on them at the last minute. And so the ideal scenario for us would be that, you know, when a family is considering end of life, when palliative and hospice is consulted, that you reach out to us. The bedside nurses know how to get a hold of us. You can find our number pretty much all over the hospital and all the ICUs. And we're happy to field a phone call at any time and discuss where we're at, if we're still following the patient, if the patient is a candidate. We can come on site and have a face-to-face conversation, or can always do one over the phone if we need to really quickly. If the family is discussing end of life and we really feel the hospital team feels like they're leaning that way, and we all as a team decide that maybe it is best for the organ donation team to go in first and talk to the family, so that we're not making one plan only to have to change it for the purposes of donation. This especially, I think, comes into play when the patient is registered and is a candidate. Because as Kristen stated earlier, it is our job at Versity Organ and all OPOs, as mandated by CMS and the UAGA, is to uphold first person authorization. So if that patient has authorized and committed and wants to be an organ donor, it's our job to make that happen if he or she is a candidate. We want to have those early conversations with palliative teams so that we're aligned in the plan for the family. Clear, concise communication is best for families, we know, and they deserve that. So we'd like to have those conversations early just to avoid any confusion for the family later on down the road. And we want to make sure that we're presenting organ donation, as we stated before, in a very time-sensitive manner. We're not always going to be able to get it perfect. It's super sensitive, and it can depend on the family on when is the right time. Every scenario is going to be a little bit different, and I think that's why open lines of communication between our teams is so important to make sure that we're serving the family the best way we can. So I'll give you a couple examples. One case that went well with communication, and one that had some areas where we felt like we could have improved. So number one was a 57-year-old male who unfortunately was a victim of an overdose. He was hospitalized for about 10 days when palliative care was consulted. Palliative went ahead and went in and talked to the family and explained what end of life would look like. And the family in that meeting made the decision to go ahead and move to a comfort-based plan of care later that evening. Started making phone calls, calling in the family. The RN notified our team after that decision was made, and the patient was a candidate. So we came in to talk to the family, and the family said, I wish you would have talked to us, before we made these plans. I've already got family on the way. Everybody's gathering. We just can't give you the time you need. And I wish you would have talked to us before we made this plan. And unfortunately, declined donation due to timing. Second scenario, we had a 61-year-old male who was also overdose. He was a registered donor and had a significant neuro injury, but was not declared deceased or brain dead. Family started making statements that they knew he wouldn't survive, and the ICU fellow mentioned comfort and hospice and therefore consulted palliative. The palliative NP actually called our team right away and will ask the bedside nurse if the organ donation team was still following. And then when was told that they were, she reached out to us, and we were able to have a collaborative conversation about what would be best for this family. And seeing as the patient was registered and was a candidate, organ donation was the next step for this family because they were choosing comfort care. And so we were able to go in and speak with the family prior to palliative going in, and therefore they didn't feel like, the organ donation process was presented immediately, and there were no changes at the last minute. So the family was very supportive of the patient's decision to be a donor. And palliative nurse practitioner still came in and spoke with the family after we did, and was still part of the care team. And so it was just a really good collaboration and supportive effort to care for that family.
Michelle, I think, I was going to say, I know we don't have a lot of time left, but we'd love to field some questions.
We have two in the chat, one from Jesslyn. She works with transplant recipients. She often sees survivor guilt in recipients. They're so grateful and happy for the gift. They're sad for the loss and the grief of the donor family. As someone who talks with donor families, do you have any recommendations or advice on how we can also support the recipients in this time? Oh, good question.
That is a good question. I think a part of me wishes I could sit down with the recipient and just share some of our donor family stories, because time and time again, we have donor families who will say, donation was the thing that helped them get through the worst time in their life. It connected them to a larger community. It was something meaningful to come out of an absolutely meaningless situation for them. And I especially have in mind a family of a young man who the family was very, they were strongly supportive of donation, and their son was too. And he was a DCD candidate, meaning that they were going to remove the breathing tube in the operating room and see if his heart would stop within, at this hospital, it was 120 minutes. And we weren't sure. This was a young, healthy guy. And when this young man's heart stopped, his parents and siblings sobbed and cheered at the same time. It was just an incredibly moving situation. It was because they knew that even though this was their loss, he was going to save lives. And that is something I would love recipients to know, that for so many of the families, this is incredibly meaningful to them. And if recipients in their own healing journey can, even in the face of survivor's guilt, make that connection, even just through writing a letter to the donor family, that will mean the world to that family. Yeah.
It's a really amazing story. Thank you for sharing that. Marty has a question. Can you talk a little bit about how you approach the hardest or worst case scenarios when the patient authorized donation, and despite your communication or emotional skills, the family still does not agree? Do you proceed? What do you do?
Well, thank you, Marty. So we do proceed, but we cannot proceed without the cooperation of the hospital. And we do so while working tirelessly with families. So I can tell you, we have had families who have initially really struggled. And this is, I would say, in any of our cases where there's an opposition, where families are really struggling, we have supportive staff at the hospital with the family, trying to work collaboratively with them to get their needs met, whether that is speeding up our process so that they can be done if they need that, whether that's working with maybe a member of their religious community if they're objecting for religious reasons, consulting with chaplains in the hospital, things like that. We have had opposition cases, I can tell you, where for 3 days a family was not happy about this, but by the 4th day, when things were settled and the organ donation proceeded, a family member told me that they would consider whoever received their loved one's gift to be like a brother or sister to them. And we never would have expected that. I mean, we work really hard, though, to come to that place where families know that they are understood, that we at least want them to experience that, and we advocate for them. But Marty, there's a whole process in place that involves executive leadership from Versity and from the hospital, and it's rather involved, but we do proceed.
Oh,
I think that brings
Maureen.
up a good opportunity, so sorry, for me to just put in another little plug. I think autonomy is so important. I think all of us who work in organ donation, I think a lot of people, right, are very supportive of organ donation. But autonomy is important. And as Kristen briefly mentioned earlier, there is a section in the advanced directive that we use here in the state of Wisconsin. On page 6, it has a spot there for you to choose. Yes, I want to donate my organs. No, I refuse to make an anatomical gift. That particular piece of paper is one of the very few things that somebody can actually say no on. If you don't check the box at the DMV, that doesn't mean no. That means I have to ask your family for consent for donation. It's not a decline, it's just not a consent. Whereas on the advanced directive, you can physically mark the box that says, I refuse. Then I don't have to ask your family. That is the patient's wishes laid out for me. So there's no other place I need to go. So I always encourage, what happens is I see a lot of advance directives that particular part of it is skipped. And I always think to myself, I wish I would know what they want. Just tell me, yes or no is okay. But, I want to support what you want, but I don't know. I had a social worker tell me once that they don't like to ask about it, because generally those are being filled out around the time of a surgery, and they don't want to create distrust or nerves from the patient. So I would just, as someone who looks at those frequently in terms of like how to proceed with donation, or do I need to talk to a family, I would just encourage that you ask, tell them it's important to fill that out and just express their desires so that we know. And then aside from that, I think registering, writing it on your advance directive, all of those things are insanely important. However, I feel like the most important thing to do is to let your family members know what you want. Because I don't want to be, and I know Kristen doesn't want to be, the first person to tell your wife, your husband, your mom, your child that you chose to be an organ donor. Because they're going through a lot of grief, and I don't want to spring that on them. I'd prefer that they already know your wishes. So I just encourage people to have open conversation with their family, expressing what their desires are surrounding organ donation.
And I think we have time for Maureen's question before we're done. She's asking, how do you handle talking to families where they have made the decision to donate, but their loved one did not have viable organs? I think I would add, or they make the decision to donate, but their loved one, as terrible as this sounds, doesn't die in time to donate. That sounds like a lot of emotional whiplash for that family.
It is. And we do work to prepare families for that. So we strive very hard to educate them in a way that doesn't give false hope, especially if you have a patient, say, who has what we call higher neuro. And so there is maybe a chance that their heart would not stop within 60 to 120 minutes. Families that have a very pro-donation culture, many of them will elect to move forward with donation because there's a chance that they could save somebody's life. We are with them in that process. So when they're in the operating room, myself or my family support colleagues, we're also there facilitating just loving interactions with their loved one. And if in either of these cases, whether their loved one did not have viable organs or does not pass in the allotted time, we do work with them to still do things like memory making. We talk a little bit about this portion of our donation community, which can seem, I think, for some people, I'm struggling with the word. We call them donors in spirit, but in reality, they are a significant part of the donation community, because we do need people who are willing to try to save a life, even if it doesn't end up working out. The amount of generosity and care involved in that moves this process, this movement forward. And so we find ways to continue to support our donors in spirit and their families however we can. But there's no easy way around it. These are hard conversations. And it can be sad and disappointing for families.
Thank you both for your time and for your really thoughtful responses to our questions. This was very interesting. It's a perspective I don't see a lot of, so this was really interesting and helpful. Thank you.
Thank you.
Thank you.
All right. Have a great weekend, everybody.